Good evening, everyone, and welcome back to night two. I'm probably going to lose track of that at some point. We have so many awesome speakers, and tonight is wonderful. We have several people on the line and lots of awesome information. So once again, I just want to welcome you to National Infertility Awareness Week, where 1 in 8 is affected by infertility, and that's more than 14,000 in North Dakota alone. We at Everlasting Hope are here to support you, whether you've been affected by infertility in the past, current, and we know unfortunately in the future there will be many more. We launched our 1 in 8 pledge today, so you might have seen that. You can find more information about that on our website under About. The 1 in 8 pledge is a simple donation of $18 to Everlasting Hope, pledging to help us break the barriers and stigma that come along with infertility and helping those in need. Don't forget, I'll be wearing different merchandise every night you can find on our website. And don't forget about our contest as well we have going on. It's pinned at the top of our Facebook page. And simply sharing our speaker lineup every night gets you entered, dropping your favorite emoji. And if you share videos, it's 5 extra entries into that. And we've also opened up our first grant cycle. You can find more information about that as well on our website. We are going to get started. We have lots of great stuff tonight. I am going to bring on Dr. Corfman. Hey, can you hear me?
Loud and clear.
Awesome. It's working.
It's working.
Love when technology is working in our favor.
Good.
So Dr. Corfman has a clinic in Minneapolis. However, he serves many of you here in North Dakota. Him and I share a passion I learned today for rural health. And we are very excited to have you as a founding partner and a speaker tonight. So thank you for all you do to give back to Everlasting Hope and those with infertility in North Dakota.
Thank you. Thanks for being willing to have me come and talk.
Yeah, so we will get started. I know you have lots of information, and at any time you just take over. But I want to also remind people that you can comment during this segment, and we will answer questions as we can. If we can't answer them at this time, we'll get back to you with the question later. But feel free to post in the comment section any questions. You can private message as well if you don't want it to be in the questions. I'll keep my eye out for that. And we can get you questions to answer afterwards as well. We also have the Stanford reproductive doctors on standby. They weren't able to make the live, but we'll get questions answered somehow by somebody. So with further ado, I hand it over to you, Dr. Corfman.
Thank you. Well, it's nice to have the chance to share some ideas with you folks and kind of give an overview about how fertility works in human beings and what are some things we can do if things are not going quite right. And so with that, I'm going to kind of start out with just sharing a little bit about my history with infertility and treating folks with have troubles conceiving. I grew up in a farming community near Wichita, Kansas, and we didn't have access to high-tech care there, really. And so it was a struggle for us. So we had to travel to the big city of Wichita, Kansas for stuff, which scared the bejesus out of us because it was a big city, we're farm people, and it was kind of hard to do. So when I finished my training at Yale, I came to Mayo Clinic and set their in vitro fertilization program up. And there developed the network of physicians basically that I helped train as residents in these communities. So I come out since 1992. I've been coming out to North Dakota to see patients first in Bismarck and Fargo, and then expanded to Minot, once in a while to Grand Forks, and try to help people stay with their local teams as much as they can. You all are blessed with some really good physicians and clinics in North Dakota. And, back 30 years ago when I finished my training, there was a big discrepancy between the care you could get locally and the care you could get in the bigger metropolitan communities. But as information has been able to share quickly, we have the advantages of being able to work with the same high-tech stuff there that we can here. It's just that to have a laboratory to provide the kind of results that we need, that needs to be in a larger city. And so that's kind of how we do it. So we reach out to folks locally, work with the local teams, and try to keep you with your local teens because they know you best, and so it makes it a nice, smooth transition from care with them. So with that in mind, I just wanted to say that I integrate agriculture with my medicine, meaning when I teach the medical students and residents how to take care of patients, it's important to be able to transfer the information that you've learned over your career through academics and through your private practice to let them have an idea about how to understand what they're going through. And so with that in mind, this first part is going to be a painful part. We're going to go back to school. And so I'm going to kind of zero in and go to a chart here, if I can figure out how to do this, Tara.
You got this.
Here we go. Okay, so this is how I start out with the word proceed, adopt, or don't have children. And I know you folks know that, but sometimes we get going down the proceed route and we might drive you past your ethical barriers or your financial barriers or religious barriers. And it's important for you to never let that happen and to be able to ask questions to understand more keenly of what your options are. And then after what I do on this sheet of paper is generally I list down the problems that you might have and so we can address them. So we know about you before you show up at our clinic, because I like to spend the time talking about your options and not your history so much. We do that before we've even walked in the room. This is what's supposed to be my artistic interpretation of the female reproductive tract. One of the things I will have to admit to you is that the farming community that I grew up in Wichita, we didn't have kindergarten. And so my lack of social skills and drawing skills comes from that. So I have a good excuse. Most of you probably went to kindergarten. You don't have that excuse, and good for you, but you're stuck with some bad artistic ability here. So here's what goes on. We have got to get the sperm and eggs to meet up here in the end of the fallopian tube. And to get out there, the sperm have to start from the vagina, through the cervical mucus, get into the uterus, through the mucus and the skinny part of the tube out to the end of the tube. Your ovary releases the egg. Your tube picks it up, brings it in. Fertilization occurs clear out here on the end of the fallopian tube. And once one sperm penetrates that egg, it hardens it so other ones can't get in. And that embryo is trapped inside that shell for 3 to 5 days before it hatches. And the embryo then bounces back between the uterus and the fallopian tube. The tube squeezes, pushes the uterus squeezes, pushes it back in the tube, and that goes on for a few days. And hopefully it will hatch and emerge and land into the lining of the uterus. So the so-called endometrium. So to get out there and to have all this work, it's all under the control of the woman having a good ovulation event. So when you ovulate, you make a cyst on your ovary that's called a follicle. And in it is an egg. And the cells that are inside of the follicle initially make estrogen and then later progesterone. And just to put it back in agricultural terms, the estrogen acts like a fertilizer, so to speak. And it hits the cervical mucus and helps prepare it so the sperm can get through. So typically, if a guy's sperm counts are normal, there's 200 million starting out here. And when the ratio between estrogen and progesterone is just right, in go 500,000 sperm. And that's under control of having a good ovulation event. So your brain, you ladies, measure estrogen, and your brain kicks out the ovulation signal that's termed LH, and that hormone makes this happen. It makes your eggs go from 2 sets of each chromosome down to 1 set of each chromosome. And it activates enzymes inside that fluid to chew the egg free so the egg comes squirting out. And you ovulate. So when the sperm get into here, they have to get out into the tube, and the estrogen also facilitates the cilia. So they beat out in that direction. And that will result in about 100,000 sperm being able to make it out here. And then while that's going on, the same estrogen is stimulating the lining of the uterus to grow thick enough to hold on to the embryo. And the progesterone, when it's made, is a stabilizer that causes blood vessels to grow into the lining of the uterus to give a good place for the embryos to land. So that's kind of what happens. And it comes into implant and starts making the pregnancy hormone HCG. Now, one of the things that's pretty amazing about reproduction in humans is that embryo, when it comes into implant, is half genetically the guy's cell surface markers, half the woman's. And which is kind of a weird deal, because if you needed a kidney transplant, you ladies, you couldn't get one just from your husband just because he cares about you or your partner. You have to be a close tissue match. Yet there's a series of blocking antibodies that protects you from attacking your own placenta. But sometimes that goes haywire, and you start making antibodies against the placenta, and the antibodies could come in and trigger the coagulation cascade that forms blood clots over the placenta, and the embryo basically starves out, and a miscarriage can happen. So that's something that can sometimes go awry. Now, I go through this for a couple of reasons. One is that to recognize that this process of ovulation controls everything. This mucus is opened up and closed by the ratio of estrogen and progesterone, and that mucus is there and there to prevent bacteria that are normal for you to have here, so none of them get to where they're not supposed to be. And so the mucus serves a very important function. So when we see couples that are trying to conceive, we have to make some assumptions about you. Number one, we like to assume that your sperm can work with your eggs, and ma'am, that your eggs can work with the sperm. Really, the only way of testing that is if you have a positive pregnancy test or with in vitro fertilization. So we make secondary guesses about that. Number two, we like to assume that your fallopian tubes are open and can function, that your uterus can work okay, and that you as a host are okay. Host meaning that you're not a smoker and your body mass index is not elevated. And so that would make that woman to be a good host. And the idea when you're trying to conceive, and if you're having difficulty, is to have everything as tuned up as possible, as much as you possibly can. So we do tests to see what's going on. And the basic test that most of you already have done, and if you haven't, your healthcare local health co-workers can help you with this, is we start out with a sperm count, a so-called semen analysis. And a semen analysis needs to be performed somewhere between 3 and 5 days after your last intercourse. That's when a guy's count is going to be the best. And if it comes back abnormal, we just simply repeat it, because it turns out that sperm counts bounce around a fair amount, and you might just have a bad day, but having 2 bad days makes us worry, and then we start doing things to see if we can get around that problem. If it comes back very abnormal, sometimes we need to do in vitro fertilization with this technique called ICSI, where the sperm is directly injected into the egg. So with that, we just need 1 sperm per egg. If it comes back normal, we're not really worried about it. If it comes back mildly abnormal, we can sometimes do intrauterine inseminations, artificial inseminations. And the idea there is to take advantage of the fact that we can prepare the sperm sample, get rid of the ones that are not moving very well, enrich it in ones that are moving more quickly, and slide a catheter in and squirt in several million sperm. And that technique can be done at any place in North Dakota, at the 3 places that we see patients, Minot, Bismarck, and Fargo. It can be done in Grand Forks as well. And so that is a nice way of getting around the problem if there is an issue there. But we're frustrated with the fact that guys with really bad sperm counts and once in a while pull this off and have pregnancy occur. So our testing is not perfect. And sometimes we can have guys who have normal sperm counts, and when we put the sperm with them in a petri dish, the sperm are not able to get into the eggs. And that's why if we get in that position of doing in vitro fertilization for a couple that we've never had a positive pregnancy test, or if their sperm counts are poor, we just do the technique where we put the single sperm into the egg. Okay, from an egg standpoint, I want to show you something that I think is important for you to kind of understand. A woman is born with all the eggs that she's going to have. And it goes something like this. Number of eggs. It goes up and slowly comes down. So when you were 20 weeks of pregnancy in your mother's womb, you had 6 million eggs. And by the time you're born, 1 million. By the time you reach puberty, you're down to 600,000. You run out when you're 50.7 years of age in the United States. That varies according to basically the nutritional background of the country in which you live. So the important thing there is that when you are 30 years of age, there's a certain percentage of your eggs are genetically abnormal, and the average 25% have abnormalities. And these percentages I have here are an underestimate because this is looking at 6 of the 23 chromosome pairs you have in your egg cells. So if we could look at all the eggs or all the chromosomes for a woman when she's 30 years of age, there's probably about 50-60% of her eggs are genetically abnormal. And as you get older, that percentage goes up. And the reason for that is that the DNA repair mechanisms that you have in your egg cells to fix damage that might occur to your DNA may not get them all fixed. So, for example, when you're 30 years of age, you're using your eggs up at the rate of 20 to 50 a month. When you ladies went through puberty, your brain became able to think that eggs and estrogen go together. You measure that in the hypothalamus. Your pituitary gland makes this hormone, follicle-stimulating hormone, that goes through the bloodstream into the ovaries, and it rises until one starts to grow. And you're going to save it. You're going to save a normal one, or you might save an abnormal one. It's a random event of which one you're going to save. So that is dictated by the blood supply. So your ovaries have this pouring out of eggs out of your ovaries each month. As you get older, the number of eggs goes down, and the percentage of abnormal eggs goes up. And that presents a dilemma for many of us as we wait to have children. Sometimes we wait because we want to get through our professional training. Sometimes we wait because of the fact we haven't found the right person to spend the rest of our life with. And when we do that, on the happiness side, we may be happier because you find the right person, which is great. And you become more financially able to deal with stressors from a financial standpoint. But the downside of it is the chance of getting pregnant goes down. So, for example, for a couple where the woman is 30 years of age, the chance of getting pregnant each month are approximately 18%. Now, why is it so low? Because it's a random event whether you're going to save a normal and an abnormal one. So if you save one that's really abnormal, it may be so abnormal that it won't let the sperm in. Or maybe normal enough to do that, but not let it divide, or not let it hatch, or not let it implant. That's all under the radar screen. That's why the success rates are about 18% per month. But if you have one that makes through all those hoops and is still abnormal, nature's going to cause you to have a miscarriage. And that's why the miscarriage rate is about 15% at age 30. So let's move forward. When you get to be 35 years of age, you're using your eggs up at a fewer number. There's a lower percentage of getting pregnant each month, higher miscarriage rate because there's a higher percentage of eggs are genetically abnormal. And it goes up significantly in terms of the percentage of abnormal eggs. So that's the story there. And it's different with the guy because sperm lasts 72 days. There are always new sperm being made. So we feel that the literature shows an increased risk for miscarriage, autism, and some mental illnesses in couples in whom the guy is over 42 years of age. Can they work if the guy's over 42 years of age? Yeah, it can. But the risk for problems starts to go up. And we just have to recognize that, and then couples make a choice. Just like they make a choice with what we do if the eggs are not quite working right, or if she's not making eggs. Now, there's some blood tests that your local healthcare team can do to find out if they think that you're having good ovulation events. One way to do that is to measure this hormone, follicle-stimulating hormone. So for this woman who's going to make a lot, let me just back up for just a second. These percentages here are all dictated essentially by a woman's date of birth. So you can make this worse. So for example, women who smoke run out of eggs on average 3.5 years earlier than women who don't smoke. That's why smoking has such a negative impact upon the chances for conception. And it'll make the efficiencies of how the eggs work to go down with time as well. So it's important not to discontinue smoking if you're already smoking. This part does not always go according to date of birth. So sometimes there's a 30-year-old who will respond like a 40-year-old and vice versa. We just know from previous studies that if we measure the follicle-stimulating hormone on day 3 of a menstrual cycle, we can get an idea about how well you're going to respond to fertility drugs. So for this woman who's going to make a lot of eggs, this should be in the range of 4 to 6, and 6 to 8, and 8 to 10, and equal to greater than 10. So by measuring that, we get an idea about how successful are we going to be using fertility medications to help you have a better ovulation event. So for example, some women with a disease called polycystic ovarian syndrome just makes enough FSH to not go up high enough to save one. So she's not going to ovulate. She's going to have irregular cycles. And so the trick then is to make this go up a little bit. Hopefully that high. We'd accept it if it goes up that high, but we don't want it to go up that high because the risk of multiples becomes a problem. So we have to be careful when we're using fertility medications to make sure that a woman doesn't make too many follicles when we're using fertility drugs. And there's 2 oral fertility drugs that have been used traditionally, one called Clomid that you may be familiar with, another one called Letrozole. And I'll show you in a little bit why we quit using Clomid several years ago because of some negative impacts that Clomid can have on the reproductive system. So we use Letrozole instead, and I'll show you that in a minute. But as you get older and the number of eggs you have goes down, your brain works harder and harder and harder to continue to squeeze an egg out of the ovary. And keep in mind, the egg that is chosen, the follicle that is chosen, is not chosen because it's the best egg. It's chosen because it can pick up the blood supply better than the other ones. And so we just have to keep that in mind. And so the oral fertility drugs, for example, are given to try to increase this a little bit to make a woman make an extra egg or two, to try to increase the likelihood that one of them you save is going to be genetically normal. So that's the story. So there's some things that can be done to find out why is this FSH level not going up high enough, and what can we do to try to make these eggs work better. So that's it from a fertility standpoint for women, for ovulation, what the status is for guys according to their date of birth and their age. Now, it turns out, going back to the guy, that okay, we're going to go back to my bad artistic ability here. So here's the testicle. And there's a gland on the side of it called the epididymis. And out of the epididymis comes the vas deferens. And the vas deferens helps transport the sperm out. It goes through the base of the prostate where there's these 2 glands to secrete a substance that makes the sperm capacitate, so to speak, because there's a cap over the head of the sperm here that prevents the enzymes that are inside the cap, the acrosome, to be exposed prematurely. So the contents of these glands help strip that cap off of the sperm so the enzymes are exposed and they can then chew their way through the eggshell to gain fertilization and to gain entry so that the genetic information from the sperm can enter into the egg for fertilization. And it turns out that the sperm in the testicle are round. They enter into the middle part of the testicle, and by the time they get into this part of the epididymis, they have developed a tail. And with ejaculation, and by the time they come out the other end of the epididymis, the tail is wiggling. That's supposed to be a wiggling sperm. and it comes out and it does this thing with fertilizing the egg. It turns out that there are some times when the barrier between the testicle and the bloodstream is broken. For example, in Minnesota and North Dakota, if you're playing hockey and you take a hockey puck to the wrong part, not only will it cause you significant pain, but it could also break that barrier, and some of the sperm can be entered into the bloodstream, which can be a problem because the sperm are recognized as being foreign, and antibody molecules can then be accumulated inside the seminal vesicles. So when the ejaculation occurs and the sperm come along, they're doing fine till they get here. By the time they come out of the testicle, the sperm can be cross-linked by the antibodies and make them so they get immobilized and they can't move. And that can lead to infertility. So trauma can cause this to be a problem. But sometimes there's blockages that can occur with the vas deferens from infectious problems. Chlamydia, gonorrhea, syphilis, the tuberculosis can cause problems. Matter of fact, just a little bit of trivia. George Washington, even though he was the father of our country, never fathered a child, never fathered a pregnancy. And the thought is that he had a brother, and I don't remember if his younger brother, his older brother, developed tuberculosis, and George went to help take care of him. And the thought is that he may have contracted tuberculosis, and that resulted in scarring of the vas deferens or the male reproductive tract, so sperm were no longer being produced. So oddly enough, the father of our country never was a biological father. Okay, so at any rate, that's how that can happen there. And one of the things we know is that the testicle raises and lowers to keep the temperature 1 degree cooler than our core body temperature. So it's going to, if you go butt naked out there in North Dakota or Minnesota in the dead of winter, your testicles are going to rise and be brought up inside. And if you're in a hot tub, they're going to try to get away to keep them cool, 1 degree cooler than our core body temperature. And that's why we suggest that couples that are trying to conceive, the guy stays out of a hot tub, because you can't cool the testicles down enough to make them function as well as they could be. So that's kind of an overview. And so there's times we can do things to make the sperm counts better. But if we can't get sperm counts to get to the point that we can do artificial inseminations, we can have a urologist see you and take a sample of the testicular tissue with a so-called testicular biopsy. And if sperm are present, freeze it to be used for in vitro fertilization with that technique ICSI, where we put the sperm directly into the egg. So that's one way of getting around that problem. Or couples where the gentleman has been in a previous relationship, has fathered a child, and he has established a new relationship, wants to have a child with that woman. We can do testicular biopsy instead of going through a reversal of the vasectomy to obtain sperm and do it with in vitro fertilization. There's a price to pay with that, meaning the price of dollars. It costs about $19,000 to $20,000 to go through an in vitro cycle at most places across the country, including ours. So it's not cheap, but it's possible. So that's kind of changed the lay of the land with as far as that goes. So for sperm, that's how we can do it. We can do in vitro fertilization with ICSI, where I need 1 sperm per egg, or we can do artificial insemination. To have this be a good option, we need equal to or greater than 2 million motile sperm by the time the lab does their preparation. And so if we don't hit that magic number, it doesn't mean it's not going to work, but it means it's not going to work as well as we would like it to. So that's the story with sperm. With eggs, we have the issue of having an adequate amount of follicle stimulating hormone made to make sure that we save a follicle. Now, I want to show you some things we do, and many of you are doing these or may be doing these in the future. We like this FSH level to go up, and to either make you make an extra egg or two if we're dealing with a couple with unexplained infertility, or if we have male factor infertility going here. But if we have a woman who's just not making enough follicle stimulating hormone, we know the brain is measuring estrogen to figure out how much of this to make. So Clomid is a potent anti-estrogen, and that anti-estrogen makes the hypothalamus think that estrogen levels are low when they're really not. The brain responds then by putting out more follicle-stimulating hormone. And that's the good thing it does. You guys, we got to keep in mind in medicine and teaching medical students that every drug we use does more than one thing. And in the instance of Clomid, it does the one thing that we want it to do, but it has a negative impact for many women in places where we don't want it to have a negative impact. So for example, wherever estrogen is working as a fertilizer, Clomid can work as an anti-fertilizer, and it can make the cervical mucus not let the sperm get through. Well, we can bypass that by doing artificial inseminations and putting several million sperm here, but that's not getting it past the mucus in this narrow part of the fallopian tube, and we really don't understand the nature of that mucus entirely. So we can do artificial inseminations, but we still have the potential problem here. An anti-estrogen can make these cilia not work appropriately. It can make it so they don't beat to the direction that we want them to, which can decrease the likelihood for sperm and eggs to get together. Lastly, but not least, is it can make the lining of uterus not develop appropriately. It can make it to become too thin. Well, we can use ultrasounds to determine that, but ultrasounds at many levels are not accurate enough to be able to predict with certainty that it can or cannot maintain a pregnancy. So why do we use Clomid? Well, it was the only drug we had for 50 years, and it's been well studied. And there are many pregnancies that have occurred from couples where the women use Clomid. But there's a significant percentage of women that do not do well with Clomid in terms of these side effects. Many women who take Clomid don't do well from a how they feel standpoint, in that Clomid is basically making your brain think that you're going through menopause like immediately. And it can make you have hot flashes. It can make you be irritable. It can make it so these other things don't work right. And so it was the only drug we had for a long time, as I mentioned. And up until about 7 or 8 years ago, if you didn't conceive with Clomid, the next step was to go to injections of follicle-stimulating hormone. Because we know that you can take shots of this hormone to make this go up, to make a follicle grow. And by doing ultrasounds, we can kind of get an idea about how well that's going to work. And so that's why when letrozole came along, we started using it. And I want to explain a little bit about letrozole. Your ovary has an enzyme system in it that's called the cytochrome P450 system. It's not important to remember the name, but we know that that hormone, or this enzyme, is an aromatase enzyme that converts testosterone and turns it into estrogen. So weirdly enough, your ovary has to have testosterone in it to make estrogen. Letrozole works by inhibiting that enzyme system, and it makes it inefficient for converting testosterone to estrogen, which makes your estrogen levels go down, which in turn makes your FSH levels go up. And it can gain the effect that we want it to have. And one of the beauties of letrozole is it does not have any of the side effects that Clomid has. But it does have one side effect. And we learned in our clinic 4 or 5 years ago that 70% of women that take letrozole block the production of estrogen so well, this goes down so low, that there's not enough to make the lining of uterus hold on to the embryo. And we've learned that we can do a blood test when the follicle's the right diameter and determine if it's too low. And if it's too low, what do? We just add on estrogen. Estrogen can be given in oral form, and that continues through the first trimester. And that has made the letrozole work extremely well to percentages in our clinic that are about 5% greater per month than we got with Clomid. So that's why we quit using letrozole for the vast majority of patients we're taking care of. There are many clinics that are still using Clomid, and there's some reasons for that we can talk about later if you have questions about that. But that's why we have moved on to using letrozole, and I think that many of our colleagues do the same. There was a paper published in the New England Journal of Medicine a few years ago that said that Clomid and letrozole, that Clomid, letrozole did not work any better than Clomid, but one of the things they failed to point out in that study was that the techniques that we're using for using these oral fertility drugs were not controlled in that study. So here's what I mean by that. Your brain makes FSH, and it makes that follicle grow. And that follicle grows at a specific rate. And we've learned from in vitro fertilization that that follicle grows, and we can measure the diameter of it. And when that diameter reaches a diameter between 15 and 25 millimeters, we should have a mature egg. And that's why we learn that from in vitro, that if we get eggs from a follicle that's smaller than that, more times than not, they're not healthy eggs, and they will not turn into a baby. So every cell makes a little bit of that estrogen, and your brain is measuring that FSH level. And when it's up to a certain level, the brain kicks out the LH surge. And remember that the LH does three things. When it gets up to this level, the cells in the ovary quit making estrogen and start making predominantly progesterone. When it gets up to this level, your eggs go from 2 sets of each chromosome down to 1 set of each chromosome. Gets up to this level, the enzymes are activated in that fluid to chew the egg free, and the egg comes squirting out. So if I show this a little bit more closely, the LH surge makes progesterone. It breaks that connection, so the egg is free floating. If we wait a little bit longer, the same enzymes chew a hole through the wall of the follicle, and the egg comes squirting out. And ovulation occurs. And if sperm at the right place at the right time, and if the tubes are functioning, that woman's going to get pregnant. Well, we've learned that nature has a way of preventing you from having more than one baby at a time if you happen to be ovulating more than one follicle. And we know that one of the things we're trying to do for couples that have unexplained infertility or mild male factor infertility, we want them to make an extra egg or two to increase the likelihood for the sperm to be able to penetrate one that's genetically normal. And nature prevents that from happening by production of a protein called inhibin, whose function is to go back to the brain to make that LH surge not go up high enough if you're making more than one egg. It might go up this high, or this high, or this high, but not high enough to hit all these thresholds. Well, how can you predict when it's time to have intercourse and when the best time to have sperm around? Well, one way we can do it is to time it using ovulation predictor kits. Ovulation predictor kits are these kits you can get over the counter at the pharmacy. You start them up on day 10. When they turn positive, it told us that the brain kicked out the LH surge. But what it does not tell us is that it went up high enough to hit all these thresholds. So we just have to keep in mind that the ovulation predictor kits may turn positive, but it does not tell us that you ovulated. It just told us that your brain kicked out that signal. Well, we've learned from in vitro fertilization that we know how to override this system, and that is that LH and HCG, the pregnancy hormone, are biochemically equivalent. The only difference is that HCG has some sugar residue stuck on the outside of that protein to make it so it lasts longer in your bloodstream. In other words, it increases the half-life. And we know that we can give a shot of that we call the trigger. And when that trigger is given, and if I look at the percentage of eggs that are ovulated, half of them are gone at 40 hours. None of them are gone at 36 hours. All of them are gone at 44 hours. That's when we want the sperm around. When we do in vitro fertilization, we like to stick a needle into that follicle at 36 hours because that's when we can suck out the fluid and the egg comes with it. It's become unstuck, so to speak, from the follicle wall. So when we do in vitro fertilization, we get the eggs at 36 hours after that trigger shot's given. When we want sperm around, we give the shot and have you have intercourse or an artificial insemination between 36 and 40 hours. That's why the timing is so precise, and when that modification has been used with either Clomid or with letrozole, it makes the success rates better. Then why do we use letrozole instead of Clomid? Because of the side effects of letrozole are not as much consequence as it is with Clomid. That's why we don't use it anymore. Okay, so that's how that works. Now I want to change gears for just a second. Yeah, I'll come back to this in a minute. We're going to talk about, so we've talked so far about sperm. We talked about eggs. What do we do if the FSH is not going up high enough to have a good ovulation event? We make it go up with Clomid or letrozole. What about fallopian tubes? We don't have a way of really telling about how well the fallopian tubes are working. We can do a relatively indirect test to look at the inside of it with a thing called an HSG. Hystero is Latin for uterus. Salpingo is fallopian tube. Gram, photograph. And that test is one where a speculum is placed into the vagina. We block off the cervix, inflate a little balloon, and put X-ray dye in that fills up the uterus, and the dye goes out through the tubes. So it's diagnostic to show your tubes are open. But for many of you, and for most of you who have not had a history of sexually transmitted diseases or ruptured appendix or things like that that can screw up fallopian tubes, we're not really thinking that you have blocked tubes. Another reason we like to do it is because we feel that flushing the fallopian tubes gives you 9 to 12 months of optimal times of conceiving. It essentially just flushes them out. And that's one of the main reasons we like to do it for couples that have unexplained infertility. Now, back in the days when I trained at Yale, between 87 and 89, we would do laparoscopies to tell about the outside of the tubes. Laparoscopy. And basically what that is to have the woman go to sleep. We make a little incision in the belly button, slide a little telescope up through the belly button. We can look inside to see, does the tube look like it can pick up the egg? And it's a very good test to tell about the outside of the egg and the ability for the tube to move to the ovary to pick it up. It's important to recognize that the fallopian tube is not attached to the ovary. Rather, it's a separate organ, and it has to get over to the ovary to pick up the egg, bring it inside the fallopian tube so the sperm can fertilize it. The problem with it is when we do the laparoscopies, you can only see the very end of the fallopian tube. You really can't see up inside the tube very far. So we don't really have a good technique to tell about the cilia that line inside the fallopian tube. When I was a lot younger at Mayo Clinic, I helped a team develop a thing called a falloposcope. And the falloposcope was a little TV camera that we could pass up through the cervix into the fallopian tube and determine if it looked like the inside of the fallopian tube was normal. But it never got approved by the FDA in the United States, but Japan, Australia, China were able to use it, and they are still using it to diagnose the inside of the fallopian tube. But it turns out we've learned from that a number of things about fallopian tubes that we can talk about later if we want to. Okay, so here we go back to these sheets. Okay, so hysterosalpingograms can tell us that the tubes are open. What they do not tell us anything about is the ability for the tube to get to the ovary to pick up the egg. So for example, if you have a disease called endometriosis, it can result in inflammation and scar tissue that can inhibit the ability for the ovary to release the egg. Now, what do I mean by that? When you have your menstrual flow, 97% of your menstrual flow comes out through the cervix. There's 3% that goes back out through the fallopian tubes. And when those cells come out through the vagina or in the fallopian tube, there's a significant percentage of those eggs that are not dead. They're still living. So when they come out through the fallopian tube and they have a chance to implant in the pelvis, they're sitting where they're not supposed to be, and they don't know it. And they just know that when fertilizer is made for the next menstrual cycle, not only will that endometrium grow thick enough to hold on to the embryo, these little cells will divide. And at month after month after month, the bleeding inside the abdominal cavity can lead to scar tissue that can inhibit the ability of the tube to pick up the egg. It can cause scar tissue or endometriosis on the surface of the ovary. And it can make it so that if the egg happens to pop out over here, it can get out okay. If it happens to pop out into the scar tissue, it physically cannot get picked up by the tube appropriately. And that's why endometriosis can be a contributing factor toward endometriosis. But one of the reasons we quit doing laparoscopies as often as we used to is that we found that there was only about 6% of the time that we found something that could explain why this woman wasn't conceiving. And so with that low of a yield, it has fallen off the list of the first things that we do for a couple who are trying to conceive. So we do a sperm count. We do some sort of a hormonal assessment to see how well her ovaries are going to work, and see if her fallopian tubes are open, if her uterus appears to be normal. There's times when we can do a thing called a sonohysterogram, which is a test that we do it just like the hysterosalpingogram, but instead of putting x-ray dye in, we put water inside the uterus. Now, what does that do for us? We draw it like this, but in reality, the inside of the uterus is a potential space. So the walls of your uterus right now, when you don't have something inside of it, they are stuck together like that. When you put fluid inside, it pushes the walls apart. So if there happens to be a polyp or something in between the palm of my hand, wherever that water goes, it's going to fill it up and you can see it. And so polyps can be identified with it. The other advantage of sonohistograms with ultrasounds is that the ultrasound lets us do cross sections through the muscle of the uterus, and we can determine if there's something inside the uterus that's not going to let it function appropriately. Like most common things are uterine fibroids. Fibroids we can talk about later if you want to. They're where the muscle of the uterus starts to divide. A woman is born with all the muscle cells that she's going to have in her ovary, in her uterus. And they get bigger and they get smaller, but they don't increase in number. But sometimes one or two of these cells will start to divide. And as they divide, they form these nodules. And these nodules can interfere with the ability for the uterus to appropriately squeeze and do its thing. And that can contribute to miscarriages. It can contribute to troubles conceiving. Depending upon the size of these fibroids, sometimes they can get to be bigger than the uterus. And that can lead toward problems with preterm labor or obstruction of the outflow tract so the baby can't adequately get out. So we take fibroids seriously if they happen to be present. Okay, so now we talked about the sperm, the eggs, the fallopian tubes, the uterus. We talked about the host. I want to talk a little bit more about the host. Testosterone is important for the ovary to be converted into estrogen. And there's two things that can contribute to testosterone. One of them is that stress hormones made by your adrenal glands can be converted into testosterone. Another one is that insulin made by the pancreas binds onto receptors in the ovary that can cause an increase in the testosterone production. So how can this be an issue? Well, we know that fat cells have enzymes in them that convert stress hormones into testosterone. And so no matter how much stress you're under, when you're really trim, you don't make enough of this to make an overproduction of testosterone. But if you have too many fat cells, it can make the testosterone levels go up. And we feel that a body mass index of less than or equal to 30 is important to have good levels of testosterone. Now, why are we zeroing in on testosterone? Because we know that excessive amounts of testosterone can cause some women to have acne or abnormal hair growth called hirsutism. Our concern with it is that testosterone has a toxic effect upon eggs when they go from this quiescent state into the active state. We know that testosterone tends to go back to the pituitary gland to make FSH levels not go up high enough to have good ovulation events. And lastly, it's associated with causing these follicles that don't make it that month to accumulate around the outside of your ovary. And these little cysts tend to be full of testosterone, which have a toxic effect upon eggs and have a negative impact upon the adequate production of follicle-stimulating hormone. This picture was given a name. Poly, Latin for many, cystic ovarian syndrome, PCOS. And syndromes differ from diseases, you guys, in that with a disease, there's one or two things you can do to diagnose it. Whereas a syndrome are a number of things fit the clinical picture. There was a study published many years ago that established criteria called the Rotterdam criteria. And it's been modified currently, and this is what we think, that if you have any two of the following five things, we think you have a component of polycystic ovarian syndrome. Number one is symptoms, are symptoms. Acne, abnormal hair growth, irregular cycles. Number two, family history of type 2 diabetes. Why is that the case? Why is it that we ask you about your family history before we see you as patients? Because type 2 diabetes is associated with the fact that when that individual eats a meal and their blood sugars go up like everybody else's, their pancreas responds by making a slight increase in the amount of insulin. And the overproduction of insulin goes right into the ovary to make it overproduce testosterone. So the overproduction of insulin in a woman who is trim can drive the testosterone levels to be elevated and can have a negative impact upon the egg production and the ability for the egg to work normally. That's how the type 2 diabetes comes into play, and that's why we asked, do you have any first-degree relatives with type 2 diabetes? Number three is an ultrasound that shows the so-called string of pearls, small little cysts around the periphery of the ovary. Now, one of the common things we see is that an ultrasound may be performed at your local facility, but when they do the ultrasounds, many times they're looking for big cysts on your ovaries. They're not looking for little ones. And they may just look at these as being normal. But depending on how many there are, it is not always normal. So it can be a tip-off that this woman might have polycystic ovarian syndrome. Fourthly is reversal of the ratio of FSH to LH. Now, normally, FSH levels are greater than LH levels, almost 2 to 1. But with polycystic ovarian syndrome, because the testosterone is going back to the pituitary gland to lower FSH secretion, the LH levels will be equal to greater than FSH levels, usually a 2 to 1 ratio for the classic polycystic ovarian syndrome. One that we feel also should be thrown into mix is a hormone called anti-Müllerian hormone. I want to tell you about anti-Müllerian hormone. Anti-Müllerian hormone has a lot of functions outside of ovulation, but we've learned that AMH levels can give us an indication about how many eggs is this woman likely to make if we stimulate them for in vitro fertilization. In fact, this drawing FSH levels and AMH levels were to give us a prediction that if this woman is going to go to in vitro fertilization, is she going to make enough eggs to go through the process? If AMH levels are really low, it would make us think that this lady is over here, and so when we stimulate her to make extra eggs for in vitro fertilization, this lady's not going to make very many eggs. This one's going to make a lot of eggs. So we can use AMH levels as an indication of that. And overall, we felt that from an AMH level, the good news and bad news. Good news would be if the AMH level is equal to greater than 1.5. Bad news if it's less than 1.0. Now, these numbers vary from clinic to clinic in terms of what they think are indicative. That's what we use. A day 3 FSH level. Good news if it's under 10. Bad news if it's equal to greater than 12. If it's in between, we're not sure what to do with that. But both of these things, if you have these numbers, it means our ability to make you make enough eggs to go forward with the process with in vitro fertilization is compromised. Now, we used that then as an indication, and we used to think, well, the higher the AMH level, the more eggs this lady is likely to produce. But the feeling is that these little follicles make AMH as well. And so if the AMH level is higher than what we think it should be for that woman's age, and we think 3.5 is a reasonable number, that would be indication that this woman has polycystic ovarian syndrome. Now, syndromes have a wide variety of presentations. So for example, the average woman who has polycystic ovarian syndrome is, let's say, 5'3", weighs 290 pounds, never gets a period on her own. She has not a very nice complexion with a lot of history of acne, and she has abnormal hair growth. She has to wax or shave her face. And it can be really a problem from an aesthetic standpoint for these women who have this syndrome. On the other end of the spectrum is a thin woman who is 5'3", weighs 120 pounds, has a nice complexion, no abnormal hair growth. But if you look at her ovaries, she has polycystic ovaries. If you do these criteria, she's going to end up with 2 or 3 of these criteria. Are they the hardcore polycystic ovarian syndrome patient? No. The one on the other side is, but when you stop and look at these criteria that I just mentioned, the women, if these are the 2 main causes for having too much testosterone, obesity can cause it, hyperinsulinemia can cause it. How is this going to be a problem? Well, long term, if a person is chronically using up insulin too much, it can burn their pancreas out, so to speak, and they end up developing type 2 diabetes. So the woman who is obese and has irregular cycles and has a strong family history of type 2 diabetes, she's got both of these things feeding into it to cause a negative impact upon egg production. But if a woman is thin, she doesn't have this going on, but she may have this going on full bore, and that can make it also not work right. So we treat this by doing things to lower the insulin secretion, in essence, lowering the insulin secretion, and that's where the medication called metformin comes into play, in case you want to talk about that later. We use birth control pills. Birth control pills work. I know, so when I see couples that she has polycystic ovarian syndrome, I say, okay, one thing you might want to consider doing is going on birth control pills. And they look at you like you're nuts. But the fact of it is that birth control pills have been approved by the FDA for treating not only contraception, but also for treating acne. Birth control pills cause the liver to increase the production of a protein called sex hormone binding globulin that sucks up testosterone out of your bloodstream and makes it bioinactive. It gets rid of the testosterone. And we've learned that 1 month of birth control pills gives you 3 to 4 good months to conceive. Matter of fact, back in the 1990s, when we started using birth control pills to prepare a woman before she went through in vitro fertilization, we did it, many clinics, especially ours, because we did our in vitros in cycles. So we choose to do it 5 times a year at Midwest Center. Some clinics run all the time. We don't, because I can't be out there seeing patients in North Dakota or Montana or Alaska or Wisconsin if you need to have your eggs harvested. So we batched them together, and we found that when we started using birth control pills, not only could we sequence you to make sure you fell when our team is there 7 days a week, but also it made the egg quality improve. And so now virtually every clinic in the world uses birth control pills because some early studies that others have published that show that it increases the percentage of normal eggs. Well, we use the same sort of approach when we're using Clomid or letrozole for a woman who has polycystic ovarian syndrome. Sure, we can give Clomid or letrozole to make FSH levels go up, But if we don't do something to lower testosterone, we feel that all we're doing is increasing the likelihood of her saving some abnormal eggs. And that's going to make their outcome not to be what we expect it to be. So polycystic ovarian syndrome is something that we commonly see in patients that we're seeing. And those are the kind of questions that we're asking, the kind of testing that we're doing to see if this woman might have polycystic ovarian syndrome. So an overview of what we do is to try see how long couples have tried on their own. It turns out that after 12 months of trying, for a couple of the women's 35 and under, if they're not pregnant after 12 cycles, something's going on. That's when we stop and do an evaluation. And those basic evaluations can be done in your local clinics in every really major city in North Dakota. If they don't get pregnant after that, and we do the evaluation, we do a sperm count, we check the fallopian tubes, we choose letrozole. Some clinics are still using Clomid. What it does is to enhance your ovulation. And the success rates go and they flatten off after 6 cycles for women under 35. 35 and over, they flatten out after 4. That's why in our clinic, we choose to not do letrozole more than 4 cycles. And if they're not pregnant then, we stop and we question the assumptions and we go to in vitro fertilization. Up until about 7 or 8 years ago, before we started using letrozole, if this didn't work, we would go to injections of follicle-stimulating hormone because we didn't have letrozole to work with. So by giving shots of that, we don't have to worry about the anti-estrogenic side effects of Clomid. We can just circumvent it by giving injections of FSH, and that got about 40% of those who didn't get pregnant with Clomid pregnant with injectable drugs. The downside of this one is it's a lot of money to do it. In fact, doing letrozole or Clomid, it's about $1,800 to $2,000 per month for most of our clinics that we're working with in North Dakota to go through 1 cycle of it. Injections of FSH is more like $3,000 to $4,000 per month. And if insurance isn't covering it, that's a lot of money for a relatively low percentage of return. That's where in vitro fertilization comes into play, because with in vitro fertilization, this couple, the woman takes shots of this to save all the eggs she can get, good ones and bad ones, put the sperm either into them or on top of them, make them grow for a number of days, and put in the best 1 or 2 embryos and freeze the remainder. Now the clinics that provide care for most of the people in North Dakota, there's 2 different schools of thought. One school of thought is that we should freeze all the embryos and don't put any in with the fresh cycle, let all the hormones get out of her system, and then put the embryos back in 1 or 2 months later. The other point of view is the one that we choose to do, which is to harvest the eggs, put them with the sperm, put in the best 1 or 2 embryos on the 5th day. Any we have left over, we grow for another day and put those into a freezer and then thaw those out and use them down the road. One of the reasons we choose to do that is because of the fact that early papers published showing on doing the freezing all showed that somewhere between 5 and 10% of patients had no embryos left after the freezing and thawing. Then they went through a fresh cycle and a frozen for no good reason. So we take advantage of the fact that we would put in just 1, sometimes 2 embryos and freeze the remainder. But I can tell you there's clinics that look at it both ways, and that's our rationale for why we do it the way we do it. Okay, I wanted to just also say that, well, I think I'm just going to leave it like that maybe. And Tara, I'm not sure if you're there or if you fell asleep during this, but we might open it up for questions that people might have. And before I do that, I just want to tell you something I tell folks when I first see them as patients with telemedicine or in person, preferably in person. Telemedicine is great, and we're forced to doing it because of the COVID-19, but there's just nothing like meeting face-to-face with a person. And so we still are planning to returning to come out to North Dakota to see patients in person. We've chosen to keep our clinic open, do all the procedures through this COVID pandemic. because there's many reasons we feel that way, and we've not shut our in vitro program down a bit, so we're going full speed. We start up another in vitro cycle in May. We had one in late March, early April. When I see patients, I tell them the two disclaimers. I'm not sure what all of you do for a living, but in your daily lives, you approach your work or your professions with a certain, doing certain things. Like if you're school teachers, you teach a certain style because you think that's the best way for you to communicate with your students and educate them. If you farm, you might farm and do things one way, and your neighbors might do them a different way. And why do you do it a different way? Because you think you're doing it the right way. The same thing is true for physicians. We all go to school. We all have done training. We all have some experiences. We all have access to the same medical literature, but we might interpret it differently. And so I just tell folks, number one, if I disagree or differ from what people have told you in the past, it doesn't always mean I think they're wrong. But then if I disagree, I need to explain why. Number two, I'm not much of a BSer. If it looks bad, you'll be the first to know. I appreciate Tara and her organization being Everlasting Hope, which is terrific. But for those of you who have ever received false hope, that is really a problem. It's hurtful. It is depressing and frustrating. And so I think it's important for you to have a relationship with your healthcare team, wherever you're at, that you can ask questions. And if you don't understand why they're doing what they're doing, ask more probing questions so they can explain it to you. Now, one of the problems with the internet and Google search is that Dr. Google can come up with all sorts of reasons for doing things a certain way. And I can tell you that it's really frustrating to know that when these couples come to put their faith in us to keep up with the medical literature, we're expected to do that, and we should be held to that standard. And we don't have time many times to answer and comment on everything that comes out on the internet. There needs to be a leap of faith that you take, that you think, okay, look, whatever the healthcare team is, you follow their protocol. And if there's something you don't understand, ask questions about why do you do it that way. It's important to be able to have that kind of a relationship with your physicians. So Tara, if you're still there, if we can open up to questions and we'll go from there.
Yes, I am here. We have wonderful questions coming in. The first the first one is, would OPKs be considered accurate for someone who has endo, or does that affect the accuracy of them?
Right. Thank you. That's a good question. Ovulation predictor kits tell you when your brain kicked out the signal to cause ovulation to occur. It does not tell us that you ovulated. Ovulation is defined as the release of a fertilizable egg from the ovary. So if you're sitting there, if you're sitting there, if this is the ovary and the follicle, and you have scar tissue covering over this part of the follicle, of the ovary, and there's nothing covering over here, your ovulation predictor kit, if that egg comes out over here, is going to show that you ovulated. If the egg comes out over here, it's going to show that you ovulated. But you didn't actually ovulate if it comes out from underneath the scar tissue. And that's why the ovulation predictor kits really are not very good at determining whether or not ovulation occurred. It just tells us that your brain kicked out the signal. So it's not really useful for endometriosis, in my opinion. Okay.
Is there any way to increase AMH levels?
No. And you guys, it's important to recognize that AMH levels and day 3 FSH levels do not tell us anything about the quality of your eggs. It tells us about the quantity of your eggs. And it's not a perfect predictor. So today, for example, I saw 2 ladies who had AMH levels of 0.5. And they both stimulated well with in vitro fertilization. So it's not a perfect test, but it's a clue. how do we use it? I point out to couples, look, if your FSH level is elevated and your AMH level is low, that's not a good sign. And it may mean that you're not going to make enough eggs to go through the process. Well, it's important for you to know how much money and emotions are you going to be out if you cancel the cycle. For most programs, the moment you walk in to have your eggs harvested is when the costs go up. So if you pull the plug short of that, you may be out $5,000 or $6,000, but you're not going to be out the $18,000 to $20,000 to go through the whole in vitro process. So I just tell folks that, and so if you're not making at least 4 follicles, we want to pull the plug and not go forward with the process because we think the success rate is going to be significantly compromised. So that's how we use it, as just an indicator of that. And then we can modify the stimulation plan to try to make that work. Okay.
Perfect. How do you decide whether to transfer 1 or 2 embryos during IVF?
That's a great question. I'll just tell you how we do it. Okay, so there's a little sign that we have in our packets when we give the grade cards to the couples, and it says, "Don't put back in more than you're willing to take home." And I point out to them, we have a no return policy in the extra kids that come from our program. In 1 or 2. And the number is dictated by 2 things, and now I think a 3rd thing. Number 1, your health. If you have diabetes, hypertension, you have any abnormalities of your uterus, your OB doc should be advising you to put in 1. And I always have the patients go back and talk to their OB docs and say, ask them how many you think you should put in. Don't put back in more than well, and your OB doc says that you should. Number 2 is infrastructure. In North Dakota and in Kansas, a lot of people, their families are still around where they grew up, and they have moms, they have potential grandparents around who cannot wait to take care of their grandkids. And I might mention that a little later on. We're going to do a seminar one evening to just talk about for your parents and the potential grandparents, so they can understand what you're going through and how can they help you mentally, financially, to get through this difficult time of your life. But if you have a support network that lets you have access to people to come into your home and help you, great. But today's world, a lot of people live a long ways away from their grandparents, from their parents. You may not have uncles and aunts nearby to help you out. So some couples that are, for example, we took care of a couple from Boston, and they moved out here to Minneapolis, and they were thinking about 1 or 2. And I go, do you have family nearby? Nope. I said, put in 1, The 3rd thing that's come into play, that when we do in vitro fertilization, if it doesn't work, there's 2 reasons why it may not have worked. One of them is we may have put in the wrong embryos. Now, they had your name on it, but it might be that we picked out the ones that were not genetically normal, because you can't tell by looking at them, but genetically normal. In fact, if you go through pre-implantation genetic diagnosis, which we do for couples that have some genetic abnormalities they don't want to pass off their kids, just because that comes back normal does not mean that embryo is normal. It's normal for the number of genes that they're looking at. But there are thousands of genes in that embryo, and you can't test for all of them. So it might be we picked out the wrong embryo, and the ones that are going to be the good ones are the ones in the freezer. That's why some programs have gone to freezing all the embryos, because of the fact that when they go through the in vitro process and they make a lot of extra eggs, their estrogen levels go sky high. And that can have a negative impact upon the development of the lining of the uterus. That's why some women do not get pregnant with fresh in vitro, despite they're putting in normal embryos. So that's why you'd like to have embryos to freeze. But again, we choose in our clinic not to put them all, to freeze them all, because of the fact that there's 5 to 10% of couples have no embryos make it through the freezing and thawing, and then they've wasted their time and money. So we'd rather do it that way. So I hope that answers the question. Picked out the wrong embryos, high estrogen levels are a problem, or infrastructure.
Perfect. For women with premature ovarian failure, how successful is IVF with donor eggs?
Great question. That is the most successful thing that any program in the world does. For two reasons. Number one, you're getting eggs from a woman generally who's 30 years of age or younger. And back in that one chart I showed with all the dots on it, for a woman who's under 30 years of age, there's a high percentage of her eggs are genetically normal. The second reason gets into that high estrogen level, the high fertilizer level. What if you make 10 follicles instead of one? Your estrogen levels are going to go up 10 times higher than what nature programmed your uterus to see. And if you make the analogy with on our farm, if my dad put on 10 times more fertilizer on his crops than he's supposed to, it is not going to go so well. And some women, the same thing true with high estrogen levels. So when you do donor, you're making her make all the eggs and all the hormones so we can artificially prepare the uterus to be perfectly ready for implantation. And that's why donor eggs works better than anything any program in the world does.
Perfect. Okay. With someone that has PCOS, are OPKs accurate? They have never had a positive OPK.
I think if you have polycystic ovarian syndrome and your OPKs are not turning positive, it's one piece of information that you are not ovulating. You're not making enough FSH to go up high enough to save one of those follicles, and you got to do something to make that level go up. That's letrozole or Clomid or injections of follicle stimulating hormone. So as a medical student, I was taught that the way you assess ovulation is to use basal body temperature charts. Because the reason for that is that when a woman ovulates and her progesterone level goes up, progesterone resets the hypothalamic temperature point and makes the basal body temperature go up. So by having a biphasic chart, it can indicate she's ovulating. Well, what they do? You go in to see your doc, and the doc gives you this stack of ovulation of basal body temperature charts and said, okay, here's the deal. First thing in the morning before you get out of bed, take your temperature, not the guy, the woman, and take your temperature and record it and keep several months of these and bring them in. I'll take a look at them. Well, it turns out that after looking at those for just 1 or 2 months, any idiot can figure out that temperature didn't go up, meaning she's not ovulating. Another way of doing that is ovulation predictor kits. Start them up in about cycle day 10. When they turn positive, it's an indication your brain kicked out the signal. But does that tell you ovulated? No. It just told that the LH went up high enough to turn that kit positive. So to me, if you've gone through 2 or 3 months at the most and your ovulation predictor kits did not turn positive, and your basal body temperature chart didn't go up in mid-cycle, it's time to go see your doc and find out what the heck is going on.
Wonderful. You're so knowledgeable. Love this. Is there any good literature on IUI versus natural, as in the number that compares the two and how much the odds increase with an IUI?
Good question. There are studies that have looked at it, and indications for IUIs would be cervical factor infertility. So in other words, Clomid can cause cervical factor infertility. If a woman has had cervical conizations or a bunch of LEEP procedures to remove abnormal cervical cells, sometimes it takes enough of the cervix to make it so the mucus producing cells are not abundant enough, and that can interfere with the ability for sperm to get through. Low sperm counts. And so artificial inseminations help there. But nobody had, okay, so let me back up. Up until about 8 years ago, there was a test called the postcoital test that many of us did, also called the Sims-Huner test. And it would be to take a sample of the cervical mucus right around the time of ovulation, have the couple have intercourse the night before, you sample it, and you look under the microscope to see how many sperm were there. And if there were 10 progressive motile sperm per high-powered field, it meant that the sperm should be able to get through the cervical mucus. If it was less than that, there was an indication for doing IUI. Well, that test has been shown to be such a bad test that nobody really does it anymore. So now, to me, if a couple sees me and they've had a positive pregnancy test before without doing artificial inseminations, that tells me there's nothing inherent about her cervical mucus that's going to kill the sperm off. And I don't think they need to do IUIs, especially people who live out in the rural areas, where it's a major hassle to drive 2 hours to get into town. You got to get your husband off the tractor or out of the oil field, come in to give a sperm sample, and then transport it in. So if they've had a positive pregnancy test before, or if his sperm count is normal, and I don't have her on Clomid, I don't see any real compelling reason to say you got to do IUIs. Now, is it going to hurt? No. But does it help? No. I want to draw one picture for you here that's going to help with that. Okay, back to this. Okay, so if you look at the number of sperm in the fallopian tube, and this study was done a long time ago, if they had romance, the sperm numbers go like that, and they last about 2 days. If we do an intrauterine insemination, the sperm number goes up and comes down. Cervical mucus acts like a slow release mechanism and covers the tube with sperm for a longer period of time. That's why when we do letrozole, or back in the days when we did Clomid, on the night of the HCG, the trigger shot, we'd have them have romance. We do an intrauterine insemination 36 to 40 hours later. So you get the advantage of both of them. That is for a couple in whom the guy's sperm counts are normal. But if sperm counts are not normal, that's a whole different deal. That means that we need to do something to bypass that drop from 200 million to 500,000. That's why we do that a little bit differently.
Perfect. Okay, let's see. Somebody has utilized Clomid and Femera. They have PCOS and endometriosis, and they've become pregnant 3 times. They've all resulted in miscarriage. Would you be able to help them with their options?
Yep. They need to do some tests to see what's going on. Is ovulation occurring okay from a hormonal standpoint? Is there not enough estrogen and progesterone? We do autoimmune testing to see if you happen to be making antibodies against your own placenta. Because sometimes you can be attacking your own placenta. And the way we prevent that from happening, it used to be in the old days, we gave steroid hormones to suppress the whole immune system so she wouldn't make antibodies against the placenta. But there's some major side effects that happen from that, so we quit doing that. We use ways of inhibiting blood clots from forming instead. So a lot of times we use low-dose aspirin, a cheap, effective way of doing it. The problem with baby aspirin is that aspirin can inhibit the ability for the egg to come out of the ovary in some women. That process of the egg being chewed free from the follicle wall is mediated by a class of hormones called prostaglandins. Aspirin inhibits prostaglandin formation. So in theory, aspirin can inhibit the ability for the egg to come out of the ovary. So what do? We start it up after ovulation. 7 days after the trigger shot, or a few days after that LH kit turns positive, start baby aspirin up, and that can be a way of preventing the blood clots from forming. And in some cases, if those blood tests for the antibodies are really abnormal, we use Lovenox, injectable blood thinners, to cause blood clots not to form. So there's some things to do. And in the worst case scenario, let's say you've tried all those things, nothing has worked, you're still having miscarriages. You could do in vitro fertilization and do genetic testing on the embryo. We take the embryos on day 5, take 3 or 4 cells out of it, send it off to the genetics lab, freeze all the embryos, get the answer back a few days later, and then after we get the answers back, then put back in embryos that look to be normal. But we have to keep in mind, again, that the genetic testing doesn't test for all the genes. It's testing for the ones that they choose to test for.
Perfect. And I did link your clinic in the comments section, so if anyone wants to refer back to that as well.
Yep.
How often does a transfer work on the first try?
Depends on the woman's age. If we put in for a woman that's under 35 years of age, and we're putting in 1 embryo, the success rate is about 50% chance of a delivery, less than a 1% chance of it splitting into identical twins. There's a 1 in 200 chance of identical twinning. If we put in 2 embryos, we have about a 68% chance of delivery, about a 70% chance of both of them sticking. So that's why we just tell people, don't put back in more than 1 to take home. If you don't have the infrastructure to take care of twins, put in 1. lets you freeze another embryo of good quality. But the days of putting in more than 2 are over. There were clinics in your region to put in more than 3 for a number of years. And the problem with that is, what happens if you get pregnant with quads? Outcome is bad, and you're faced with the decision of doing multifetal reduction, which is a tough deal. So even if you're pro-choice, the thought about going in to reduce an embryo, 3 babies down to 2 or 4 babies down to 2, that's a difficult process. So that's why back in 1996 was the last time we put in more than 2 embryos, because I had a couple who got triplets. They lost them all. I was going, nope, not going to do that ever again. So we put in no more than 2 starting then.
Wonderful. Do you use InvoCell at all?
We are going to start using InvoCell. We've gone through the training for it. We're just getting ready to ramp it up. But I can tell you, I don't think it's a really good idea. We're going to offer it, but there's a lot of things it doesn't tell us. It doesn't let us have embryos to freeze. And I think that it's going to end up being a ripoff in the end. It's a marketing gimmick, in my opinion. And it's a way of getting people to come into your clinic because I think they're doing things more naturally. But you lose so much of the advantage you get of making these embryos grow for a number of days before you put in the best 1 or 2. So we're offering it, but I think the usefulness of it is not going to be there in the long term. Good question, though.
Yeah, these are so good. What can be done to help with male factor infertility? This individual is ovulating with medications. They've done 3 failed IUIs.
The magic number after the clinic does the prep is 2 million moving sperm. So if you're not hitting 2 million moving sperm for that insemination, the next step is in vitro fertilization. But if your wife is 35 and under, we would do the inseminations up to 6 cycles before we'd give up on it. And that goes back to that one curve with letrozole and Clomid. Well, I'll say with letrozole. Let me just write these numbers down. I'm going to go click back to that. Tara, we doing okay with time?
Yep.
Okay. So we're going to zero in on this. With letrozole, 22% chance of conceiving. And we're talking about for this group, under 35. 22%, 22%, 18%, 12%, 6% becomes less than 1% per month. That's why we don't do it more than 6 cycles. And Clomid, just to give an example, is about 16%, 16%, 16%, 14%, 8%, 3%, less than 1% per month. This is letrozole. This is Clomid. Why is it lower? Because the anti-estrogenic side effects of Clomid. And that's why we don't do it more than that. So the same thing's true with sperm. If you're doing these cycles and you're putting in 2 million moving sperm or more, then we don't do it more than 6 cycles. But you might look at these numbers and go, hey, you bozo, success rates are starting to drop off after 3. Why do we want to do it for less success? Well, you might not, especially if you're paying for this out of your own pocket. But if some insurances are covering it, well, they might cover it. It might be $100 copay, and they might do this for 6 cycles. But if you're paying for it out of your own pocket, success rates are starting to dwindle off after 3 cycles, and then it's time to do something different. The other thing about that is if your sperm counts are not hitting the magic 2 million moving sperm, you're not going to hit the success rate that I just put. And so that would lead you maybe to move on to in vitro sooner than later. And, you know, another thing to keep in mind is donor sperm works well, too. It's just nobody's first choice. And I'm gonna do another page here. If I can find a piece of paper. Terry, can we have like 10 more minutes?
Yes. Yep.
Okay.
There was one question about what you were just saying. Was that talking about consecutive cycles?
It doesn't make any difference whether consecutive or not. They can be consecutive cycles. There's no downside of doing consecutive cycles. And there's no advantage of waiting either. But I just tell folks, look, if you're getting burned out, just take some time off for good behavior. And or bring your wife chocolate and roses, for crying out loud. Man, that will help things maybe smooth out a little bit too. Okay, so now I'm going to draw something. This is how I end up the consultations with most of the folks we're taking care of, with this sheet of paper. Here are all the options this couple has. They can decide to have no children. They could decide to adopt. They could decide to do letrozole with or without intrauterine inseminations for 4 to 6 cycles. They could do in vitro fertilization with her eggs and his sperm. They could do in vitro fertilization with donor eggs plus or minus donor sperm. They could receive donor embryos. Those are the options. And then we go cost, chances of delivery per method, the multiple pregnancy rate, genetics, who's the genetic mother, who's the genetic father, who's the host, who's carrying the pregnancy, and other considerations. So we're going to say for the couple where the woman is, say, 35 years of age. By the time you do this, it's about, we'll round it off to $2,000 a month if you're doing inseminations. You end up with $10,000 to $12,000 into it. Chance of delivery are going to be 60% after 6 cycles, 8% chance of multiples. She's the genetic mother, he's the genetic father, she's carrying the pregnancy, other, it's expensive. In vitro fertilization, $19,000 to $20,000 by the time you're done with everything. Putting in 1 embryo, 50% chance of a delivery, less than 1% chance of splitting in identical twins. If they put in 2 embryos, 68% chance of a delivery, 70% chance of multiples. And basically, if you put in 2, you just have to be prepared to go home with 2. She's the genetic mother, he's the genetic father. She's carrying the pregnancy. It's more expensive. In vitro with donor eggs is about $26,000 to go through that once, because we pay the donor $6,000 to donate eggs. If they put in 1 embryo, they have a 55% chance of delivery, less than 1% chance of it splitting. 2 embryos, regardless of the woman's age, all the way up to age 45, is about 74% chance of delivery, about a 75% chance of multiples. Not the genetic mother, or not the genetic father. She's carrying the pregnancy. It's expensive. There's ethical issues there. Times 1 to 2, depends if you change just the eggs or the sperm. Need to manage the risk of multiples. Don't put in more than you're willing to take home. Donor eggs or donor embryos. These are embryos from other couples that don't have any more kids and they got a bunch in the freezer. It's about $9,000 to go through that one time. 40% chance of delivery, 40% chance of multiples. Not the genetic mother, not the genetic father. She's carrying the pregnancy. It's expensive, but not as bad as in vitro with fresh eggs. There's ethical issues there, times 2. That's that one. The other one that are donor eggs is you're likely to have embryos to freeze. And then you got to do something with them. Same thing true with in vitro over here. You either got to use them, or you donate them to other couples, or you discard them. Adoption, $18,000 to $40,000 to adopt. They have high chances of adopting, 1% of adopting multiples. not the genetic mother, not the genetic father, not carrying the pregnancy. It's expensive. There's ethical issues there too, times two. Big one for us is this one. You don't know about the health of the mom or the dad or how they take care of themselves during a pregnancy. You guys, this chart at the end of your consultation with whoever you're seeing, you really should try to put together something like this because it can make it a difference in how you analyze the data and what decisions you like to make. It's okay to go through these in vitro or letrozole. If it doesn't work, donor eggs is still an option, so is donor embryos. If you have premature ovarian failure or if your AMH levels are low and your FH levels are high, and if you said, look, we're going to go through one big ticket item one time, we're going to go through either this or this. If you don't make enough eggs to go through it with it here, this is a waste of money. This is where you should be going. But not if it's going to drive you past your ethical limits. And that gets back then to the question about, back to the beginning, proceeding, adopting, or don't have children. That chart that I just wrote out at the end of our consultations with virtually every couple that I see, we go through that with them to apply it to their success rates. So if she's 37, 38 years of age, you can look at these numbers, and in vitro fertilization is more like a 40% chance of a delivery. 40% chance for $20,000 versus 74% for $26,000. This is more cost effective. But then you have to worry about the ethical issues that go with it. So you don't want to ever look back and think you did the wrong thing. And one of the things Tara, I forgot to tell you this afternoon, is I teach reproductive biology at NDSU every year in the biology department, and try to help these young kids kind of understand a little bit about what they're learning, how to apply it. And I just point out to them that no matter what they do in their walks of life, you never want to look back and think you did the wrong thing. And especially when it comes time to having children, that if these options we've talked about are not alternatives for you, it's okay. But then you need to be in a position to be a really good adoptive parent or a good uncle or an aunt, and to help enjoy the gift of life by helping become a better uncle or aunt or whatever. So, okay, other questions?
That was a great chart, by the way.
Thank you.
There is one last question. Is there any way to test cervical mucus?
No, there is not. And that test I was telling you about, this Sims-Uner test, we used to do it, but the false positive and false negative rates are so high, we just think there's a problem. Talking about false negatives and false positives, coronavirus, it's on everybody's mind, and there is no evidence that it caused any trouble for babies or embryos or pregnancies. And so that's one of the reasons why we move full steam ahead when this is going on. We don't think there's any issues with that at all. And that's why we're doing it. That data comes from the H1N1 virus and the SARS virus were also coronavirus members. And that when those pandemics went along a long time ago, they were carefully studied. And so we feel comfortable. We're just waiting for the economy to open back up, and not to get into politics, but we got to get our business opened up again, and especially places like North Dakota and rural Minnesota, for crying out loud. It's not like we have the population centers that they do in New York City or New Orleans or Detroit or Chicago. So I am just praying every morning. Wake up and I'm going, man, I hope the governor opens it up and lets us get going back to normal things, but it's not quite there yet.
Yeah, it's been frustrating for sure. And I know in the infertility community, people are waiting and staying hopeful the best they can with everything.
Yeah, we're not waiting. We're still doing everything the way we did for a number of reasons. So I don't think there's any reason to wait.
Okay.
Yep.
Good to know. There was a follow-up to what we just talked about with cervical mucus. How do you know if there's a problem or not with the natural or IUI decision? I hope that makes sense.
Say that again, would you please?
How do you know if it's a problem or not? Like cervical mucus, I think they're referring to if it's a problem with natural or the IUI decision.
You don't know. And if your partner's sperm counts are normal, we have no way of knowing if it's okay or not. So that's why I just think that if it's convenient for you to do, then do the inseminations. But if it's not, if your husband's sperm count is normal and if you're on letrozole, there's no real compelling reason why you have to do IUIs. But Clomid is a whole different deal. Clomid definitely tends to screw up cervical mucus for women more often than not. And that's why we would definitely do that if that's the case.
Okay. We've had a lot of thank yous. We've had a couple people that you've successfully helped with come on. And thank you.
Hey, there's you got the contact information?
Yes, I put it in the comment section and I'll link it to our YouTube video as well. And you're also in our resource section. So on our website under resources for IUI, IVF, you're listed underneath there as well.
That's fine. Well, fortunately, you guys have some really good clinics in your state that can do all the basic stuff. So it's not like most of you don't need in vitro, quite frankly. We find that in our population, only 20% of people need in vitro. 80% don't. We get them to the point of having a family, building a family without needing to do that. But there's 20% that need it. And so we don't want to be looked at as just an IVF clinic. And same way through with your local clinics there. So.
Excellent.
Okay.
Thank you so much for being with us this evening and your wonderful information. This will be saved on Facebook and as well as uploaded to our YouTube channel. So if anyone missed it, or it can be shared as well off of there.
Super.
Thank you, everyone, for joining us.
Thank you. Have a good night.